Good morning, everyone. I'm Ashley Adamson, and welcome to the second day of the Inequalities Prevention National Symposium. And this is my role is prevention lead for our North East North Cumbria ARC, but most importantly, in terms of the national consortia for prevention, including behavioural risk factors. So I'm really delighted to see everybody. And somebody remarked last night that actually seeing people pop out of those little boxes for the very first time, there's many people meeting each other for the first time because the consortia was established during lockdown. So this is the very first time we've had a chance to get together yesterday and today. The other thing to say is I'm very sorry. This is my hometown, and I'm sorry about the weather. It very rarely rains in York. It really doesn't very often rain. Okay. We've got, I think, really to say that obviously we've got people from across 15 ARCs joining us today, and there's going to be lots of presentations as yesterday, and I hope you have a wonderful day. I want to also particularly welcome our colleagues who are coming from public health practice and also our public members. And I know those of you here yesterday met a number of our members from our public panel. So it's great to have you all with us again today. I'm just going to introduce a little bit about the consortium and some of the projects that will be presented today. So this is what we're doing, working together to reduce poor health, prevent early death across the life course. And of course, what the consortia of the ARCs does is allow us to look at projects and also evaluation of things that have been implemented that across geographies. So individual ARCs are all doing amazing work, and we've got some good examples of that today. But the cross-ARC consortia give us that additional advantage of being able to bring expertise together and also to look at things that are being implemented across geographies. So that's the advantage of that, and also, of course, for people working on the projects to also begin to build their networks, and something that people have really missed out on over the last couple of years. So these are the 5 projects that we are funding under the consortia funding. So one is around the enhanced service for weight management in primary care, and you'll hear more about that today, and that's part of the national rollout of that, so that we're being able to do an evaluation of it. The next is a similar one around type 2 diabetes prevention and across glycemic risk tiers, and you'll hear more about that one too. The next project, again, is around the NHS long-term plan implementation around tobacco and the tobacco dependence services. So again, that involves a number of ARCs like all of the others, and that opportunity to be in different settings. And then we have a project that's been evaluated, which is about workplace health and cluster randomised controlled trials of behaviour change intervention. And again, you'll hear presentations on that. And then the 5th one is one that we're delighted that we are funding cross-consortia. So there are consortia in different topics. We have 2 that our symposium is around, and yesterday was inequalities and today prevention, and we work very closely together. I mean, there's a lot of grey area and difficult to put a piece of paper between those two, the overlap between them. But this one on the domestic violence advisor provision in maternity setting, we're co-funding with the consortia, which is around maternal and child health, that's led by Stuart Logan in Exeter. So they're the 5 projects, and you'll hear more about all of those today. So now I'm going to introduce Professor Peter Kelly. And Professor Peter Kelly is the NHS Director of Public Health in North East and Yorkshire Office for the Office of Health Inequalities and Disparity. It is office. It's not what it says here. Anyway, we call it OHID for kind of obvious reasons. Okay, so Peter joined PHE Public Health England, just in case anybody can't remember about that, in September 16 as the Centre Director in the North East, and previously had been at DPH and Stockton-on-Tees before that. And so he's been a Director of Public Health for 11 years in various posts, and in 2020 took up the role of PHE Director, Regional Director and NHS Director for Public Health for North East and Yorkshire. So Peter's domain is gradually increasing. It was the North East, then it's North East and Yorkshire. And his responsibilities including leading the provision of high quality, responsive expert public health advice service to support local authorities, NHS partners in North East and Yorkshire. So obviously a lot of interest in some of the projects that you'll be hearing about today. Now, Peter also started, before he went into that, as a medical statistician. So just check his stats on your posters as Peter's going around, and completes his PhD in stats in 1987 and was a lecturer at the medical school until 1996. And that's where Peter and I's paths overlapped, because I was in the university in 1994. So the alternate introduction to Peter is that Peter's a random bloke I've known for 30 years, and we've dragged him off the street to come and talk to you today. Okay, so Peter, you're really welcome, and we're looking forward to what you've got to say.
So first of all, can I just say thank you for the invitation this morning. It really is quite a privilege and honour to be asked to come and speak at an event like this, and it's so I don't take it lightly. I'm really very honoured and privileged to be here. And when I was asked to think of a title, so I was asked to do the talk many months ago, and then about a month ago, any chance to let us know what you're going to talk about, Peter? So I thought I'd better do that bit. So I've came up with this title. The shorthand for the title is Reflections upon Prevention and Health Inequalities. The really shorthand is just Reflections, because it's given me the chance to think about, I suppose, the work I've been involved with from a practice side for many, many years in a variety of direct public health roles, where you keep engaged and in touch with what's going on in the academic world and all the incredible, fantastic reports and pieces of work that I've done, but you can't get into the depth of it that colleagues in this room do. So I decided at the very beginning, before I did this talk, I'm not going to get the depth of academia with an academic audience of such as yourselves, because I'll be on a loser. So what I want to do is try and reflect a little bit of my world and the thought process of public health over a number of generations, and just to leave us something to think about. I'd be quite disappointed at the end if there aren't some things I've said which you disagree with, or might even occasionally irritate some of you. I hope there'll be some bits that you'll like as well. I think, yeah, you've got a point there. And what I'd really like at the end is a bit of time for a good discussion and a chat about some of the things I'm reflecting upon myself. The second thing I need to talk about is, in some seriousness, about my role and why it matters today. So there are two important public health speeches today and events. One's me now, and us. The other's the Chancellor. And you can take your pick as to which you think is going to have the greater public health depth. But in my role as Regional Director of the Office of Health Improvement and Disparities at North East and Yorkshire, I'm one of the most senior civil servants in the north of England for the government. It's a very senior civil service role. And my job as a civil servant is to support the government of the day, to help them formulate policy and to implement their policies. That is the job of a civil servant. And it's really important as a civil servant that at all places where we work, that we are consistent on that and that we are faithful to that, because that's how our system works. Internally, we give all sorts of advice to ministers and to people formulating policy. The second part of my role, which is genuinely a joint role, is with the NHS. So I'm also the Regional Director of Public Health for the NHS for the North East and Yorkshire. 27 local authorities, 4 of the biggest ICBs in the country, 8.5 million people more or less, the most stark inequalities in the country, the North West has some as well, pretty bad. But overall, you know, we struggle. So that's the other part of my day job. So I split into 2 roles, and I chair as an academic interest, and it is something I do to help. So I always enjoy doing. It keeps me in touch with academic colleagues in the room. I've chaired the Fuse board 4 more years. I probably remember, but about 10 years at least, I think. It's something I always do enjoy doing. So when I'm making my remarks, they are tempered by the fact that I'm a senior civil servant and I'm an NHS regional director. Okay? And it's important that we remember that. Well, that's actually, it's most important I remember that, actually, rather than you all remember that. It's very important I remember that. So, I'm going to start off with a little bit of very recent reflection. And this was picked up yesterday in Peter's excellent talk, the other Peter. This is data on early data we had on mortality from COVID in the very first wave of the pandemic. There's no surprise in it. You'll have all seen this type of data before. There's nothing special in it. The dark red bars are females, the light blue bars are males. So there was a high mortality rate in men. And this data was up until about the end of April 2020. So very much the first wave of the pandemic. It was actually published on the 13th of May, but it was internally, with the cut-off date, was about the very end of April. If you remember, the first wave of the pandemic peaked around the Easter weekend of April 2020, around the 9th, 10th of April. The point I want to make about this is that I don't think there'd be anybody in this room who would be surprised at that pattern. There was lots of people who were surprised by that pattern in the world I work in. It was, oh, wow, all those people in the deprived areas have got much higher mortality rate of COVID. Why is that happening? Duh. Sorry, but, you know, honestly, there was that reaction a lot. And so the pandemic did highlight, again, as Peter said yesterday, that actually inequalities, structural inequalities, because that's what these are, do have an impact and they do matter. At the same report, and again, this won't surprise anybody, this is data from, again, by the end of April, the first wave, so even through the first wave, describing mortality by ethnicity. You can see there's an awful lot of other in here. So the first point I want to make is that that's because it wasn't recorded very well, or at all. And secondly, you can see the high mortality rates and the black groups, the Asian groups, and frankly all the groups above the white groups. And again, that's a surprise in some quarters. But of course, I would be surprised if anybody in this room was surprised by that. So the point of me showing these 2 graphs is not the data in them, because you know all that. It's the fact that this information did come as a bit of a surprise. That type of stuff went to the front page of newspapers. It affected ministers' thinking and questions. And it did lead to something quite positive in this particular area, ethnicity. It became to be a realisation that actually it wasn't easy collecting this data for this particular study, because the NHS doesn't routinely collect ethnicity data on people who use its services. Or didn't then. Hospitals are now meant to record ethnicity data on everybody using their services. That was put in place some time after this. There's been a big improvement, but it's still not perfect. There's still many trusts that still don't collect data on ethnicity in the way others do. And there are some trusts who do it brilliantly and have it almost perfect. So immediately there's some variation. That's a variation, that's an inequality which can be fixed by some management action, put something in place to make something happen. Because how do you know if there aren't any disadvantages, inequalities in access to care and outcomes for care around ethnicity if you don't measure it? Something as fundamental as that. Anyway, that was just an opening just to explain a little bit of some of the thinking that goes on in the background, or some of the conversations we end up in. But I want to go back to somebody who's, I know, by the way, at this point, I'm just going to make my only prop of the day, is I did bring this book with me. And it's one of Claire's books, Health, Inequalities, just to prove to Claire, I saw Claire yesterday, so I've been reading this in preparation for today. So I just wanted Claire to know I had been reading in preparation, Claire. But George McGonigal was the chief next slide. George McGonigal was the chief medical officer of Stockton-on-Tees from 1924 to 1939. As a sign of the times, often mentioned, in 1939, I think he died at age 49, pneumonia, in 1939. And he was quite a pioneer in his age amongst chief medical officers. And there's many people who have written things about it, so I'm not going to go into too much of that. I'll use two of his quotes at the beginning and the end of my talk today, and this is the one I'm starting with. Where he was a chief medical officer based in Stockton District Council, where the responsibility for the health of Stockton residents were his in the council structure time, the 1920s and 30s. Housing, ambulances, mother's health, children's health, that type of stuff. Food supply, food quality. And he was a real advocate for the power of the local government, so the broad determinants of all the things that affect people's lives, employment, unemployment, quality of employment, education, housing, diet, rather than what you might call a medical type prevention approach, which of course hadn't really been thought of very much in the 1920s and 30s. One of his, something I've actually called, I don't want to actually discuss this with Claire afterwards perhaps, but something I'm actually calling the McGonigal effect now. Because one of his studies, he looked at a change in housing patterns in Stockton. And again, many of you will know this, but I'll just very briefly talk about it. There was some real Victorian, crowded insanitary type slums in the riverside area of Stockton. And effectively, there's a house clearance scheme that moved them to nicer houses half a mile or a mile away. But the income of these people was fixed. Quite small income. Unemployment in the population that moved varied over time between 20 and 40%. And that's male unemployment because far few women worked. And the rent was, the income was fixed, but the rent doubled. Now, think where I'm going to in today's context. So people were very, very poor with fixed income, no opportunity to expand their income to get extra income in. Their amount they spent on rent went right up, so something had to give. What gave was the money they spent on food, in quantity and in quality. And broadly, when you look into it, what he demonstrated was that the only thing that changed was basically the money spent on food went right down, and the money went on rent went right up, and mortality increased quite significantly in comparison to very similar local areas. For those of you who are in the stage of studying and learning epidemiology, I would urge you to read some of his early papers. It's really good, fundamental, basic epidemiology, which I would urge everybody, just as a learning exercise, to have a look at and think about. So my concern, the lesson in this for me, is why I call it the McGonigal effect, is where we are today, where people have fixed incomes, a part of that income is going up through the roof, and something's got to give. So what's the consequence of what gives? The consequence then was a high mortality rate. What's the consequence now? Is it going to be impact on mental health? Is it going to be more addiction? Is it going to be raised mortality from a range of different things, so through the stress factors which that all brings, and the poor diet and poor nutrition? It remains to be seen. But I do worry about it. And then I want to move on to Peter Townsend. We often talk about McGonigal in the North East gets talked about. We talked about the Black Report and the HL Marmot. We come on to them. How does it Peter Townsend quite gets the exposure he deserves in the public health arena? He did some really interesting work in the 1950s and 60s, where he was looking at a range of different data from the 50s and 60s, post particularly the NHS, and examining the theory that the NHS had really helped everybody's health. Poverty increased in the 1950s, didn't decrease. He showed that very clearly in some of his work. And he had this theory about, wasn't just as simple as poverty, but what poverty led to, the lack of participation. So again, this is a theme which I think is very strong today. So a group of people, and he postulated the threshold was around the 30%, and there's been studies looking at that, and in a way, the threshold doesn't matter. But what he's postulating was that there was a group of people who simply don't engage with society in any of its forms. So if you're going to start putting prevention programs in place, or stop smoking services, or weight management services, in our context, they aren't going to engage. So it leads you to, really, Tudor Hart's inverse care law. Not just because the people like us access it, I say us broadly, but also as people who need to access it don't at the other end. It almost fulfills a prophecy. And this is not rocket science, but again, the 1950s and 60s people didn't buy into this. But I don't think any of us would disagree that ethnicity, age, employment all starts to link into this, because they are all confounded. And then, of course, low income restricts choice. Blindingly obvious, but it's really important, therefore, we don't build policies which are based upon choice if your aim is to try and improve the health of the people at who are struggling the most. And then, again, links into McGonagall. People on the lowest incomes have to choose between basic necessities. Blindingly obvious again. But it does need stating, and it needs backing up with an evidence base, of which there's a lot in the literature, and people in this room have written a lot on. And that's what's happening in Stockholm and McGonagall. They were choosing between necessities. Do you pay the rent, or do you buy food? And again, we have to be very careful we don't forget that, because as I go through the rest of my remarks, there is a theme in this. So I've often said to people, I've got this vast, I've been at DPH about 20 years in different places, and all, different councils and PCTs. I stopped worrying about, and don't take this the wrong way, but I stopped worrying about people like us a long time ago. I do worry about people in the bottom quintile, bottom decile. They worry me the most. On the whole, the rest of us move along quite nicely. We have our problems, we need services. But the people I really worry about are that lot at the bottom. Then we have the Black Report. And there's others in between, but this is not a complete academic history. I know I'm not getting this marked, I hope, by anybody in the room, so I'm missing bits. It's not a Viva or anything like that, public Viva. So, Professor Bambra's taking notes at the front, I'm in trouble. But he described in great detail the unequal distribution of ill health mortality for the UK. It's a very, I'm sure you all be at least familiar with it, many haven't actually read it, I'm sure page by page. And again, he came to the very clear conclusion, it was all around the things we know about the wider determinants. It wasn't around the choices people are making. It was all around all of that. And he recommended a whole series of social policy interventions, precisely none of which were put in place. Then we have Rose, and I think the Rose hypothesis again is something which I think we should make more of. But it's also challenging to people, the Rose hypothesis. So what Rose basically said was actually just looking at the people at the bottom end by itself, whilst it's attractive, doesn't do the job. You've actually got to move the whole population forward, and when you do that, you take the people in the lowest 5-10% with you. That's more or less the Rose hypothesis. And he was applying that, particularly to cardiovascular disease prevention, for which there was starting to be more attention to by the time the early 1980s came along. So he talks about this here, shift the distribution of the risk variable. I'm going to come to him a little later and compare some of that with, or integrate some of that with some of Marmot's thoughts. Then we have Aitchison, 1998. Health impact assessments in all policies, health in all policies effectively type approach. I tried that at Stockton Council. Didn't go down very well, particularly with the entire executive team. It was like a little bit of, there was resistance to it, in the grounds that they struggled with some of the links. And they said, well, you could put economy in all policies. I said, yeah, well, that's public health, that'll do. You could put employment in all policies. Well, yeah, that's public health, that'll do. So anyway, you end up compromising. But it's in some places, that's actually a harder sell than you would imagine. Talk about having a DPH in every health authority. And we had health authorities then in 1998. That's how the system was. We've had a few changes in the restructuring NHS since then. But I joined the health authority in the NHS in 2000. And there was a DPH, Professor Paul Johnson. And in this last bit, place a partnership duty on the NHS and regional government to work together. Well, we now simply got the integrated care boards. But we've had other attempts at this over the years. And with mixed success. I mean, regional government is now abolished. It was abolished in 2012, regional government. So we don't have regional government anymore. We do have local government, and there are integrated care boards for those that are going to work properly and work well. They really need a proper partnership between the councils they work with and the NHS side. It's not just an NHS body. It might be in legislation, but in spirit and the way it's meant to work, it's actually all HSN. All HSN, I would suggest, for those who are really going to make it work. And the next I want to reflect upon, and all of this shapes my thinking, is Wanless. And the reason I particularly looked at Wanless is 20 years ago. And Wanless made some predictions for 2022. Wanless did. He made these, I don't know why he ever did it as solid, slow, fully, and not slow, solid, fully, but anyway, solid progress, slow uptake, fully engaged. Won't read all the words out, but on each of those, he's talking about engagement roughly in the slow uptake one in the middle. The health state of the population is constant or deteriorates. Well, discuss. We saw some data yesterday, didn't we, from Peter on York, where certainly over the last 10 years, the health status has remained constant and has shown evidence of deteriorating. So that, I would say, was pretty much a slow uptake. The solid progress is people have confidence in primary care and use it appropriately. There's massive pressure on primary care at the moment, and we've really struggled to try and get the number of GPs, and there's a real crisis almost in primary care. Then fully engaged. Life expectancy goes beyond current forecasts. Health status improves dramatically. Hands up, everybody thinks we've achieved fully engaged. I thought that'd be a short question. But I want to pick up on, though, the highlighted bits. He based his 3 scenarios on what he described as public engagement. But it's also quite personal. In the slow uptake, no change in level of public engagement. In the solid one, people become more engaged with regard to their own health. That's personal. That's taking care of your own health. That's personal responsibility. Fully engaged, high levels of public engagement with regard to their own health. That's personal again. So just think back where we've got so far. We've got McGonagall with very poor people struggling. We've got Townsend showing that people who have less income don't participate much in society. We've got the Black Report with all the structural and wide determinants. We've got Aitchison by now talking about, again, health in all policies. This, in some respects, is quite retrograde, because he's talking about the person taking responsibility behind this to achieve these 3, well, depending upon which of these 3 scenarios end up in. The other bit he was actually, and remember Wanless was actually a banker. So the other thing he was very interested in was spend. And he was actually commissioned by, I think, Gordon Brown to do this rather than the Secretary of State for Health at the time. So in 2002, 7.7% of the GDP of the UK was on health spend. And he predicted under these scenarios that if we were really good and we managed fully engaged, we'd be 10.6 GDP in 20 years. And the reason it's going up is because of the ageing population demography. That's the fundamental reason. So he saw that, he predicted that as a problem. He said, if we don't do anything about it, we make no progress, 12.5% GDP by the time, in 20 years' time. And if we make some progress, we're in the middle somewhere, about 11%. Well, I looked up the GDP figures, the latest I could find, for 20 years on. And according to the ONS, it's 12% of health spend in the UK is GDP. So we are somewhere between more towards a slow uptake, nowhere, than the solid progress, and absolutely nowhere near fully engaged. In cash terms, that is absolutely tens and tens of billions of pounds. And what sort of crisis we have at the moment? Much than anything else, we have a financial crisis, for which the other public health speaker will be talking about in Parliament this morning. So if we'd done this, if we'd really gone down this road, that is what Walner said we could have achieved. And actually, I think his ballpark figures of where we were going, given where we're at, were actually pretty impressive. But it was based upon, in my mind, the wrong premise. Getting individuals to take control of their own lives, when that control in many cases is not in their hands. Marmot, 2010. You'll all be aware of Marmot's six main recommendations and all the excellent work behind them. They are very, very powerful. When I think of the title I was talking about here, I do an aspiration in. They are aspirational. Who would not want to give every child the best start in life? Well, of course we all would. Could we define what the best start in life is? And when it says every, it doesn't say 99%. It doesn't say 99.9%. It says every. Well, at least 30% of children live in poverty in the northeast of England. They ain't got the best start. And that's just one metric. Think of the children living in poor housing, the children who don't have good access to good education, the children who are in troubled families, the circumstances. So that is, we should all be driving towards that, but don't get discouraged that we never achieve it, because we never will. It is aspirational. But it's fantastic as a target and a drive, which we should be doing. And you go through all of them and you start looking through that lens. What's particularly important as a concept is proportionate universalism, where effectively, in my mind, he's taking rows and saying, yeah, we've got to do rows. We've also got to push the bottom end up more, harder and faster. So for me, he's taking rows a step further. And I've got an example on that, which I think might illustrate that. I'd be interested in people's thoughts. So I've gone through, in a way, a very high level, some of the key bits which I think shape my thinking, but shape the thinking of us as a public health community, from McGonagall all the way through to Marmot. And what strikes me with all of this is if we aren't careful, we'll miss the point. The point really is about those people in the bottom end of society who we've got to find a way of engaging with, not telling them what to do, not necessarily providing them with more services even, but you've got to fundamentally find a way of getting them involved in participation in society. I visited the North East Council last week, some really good stuff going on, Sunderland Council, some fantastic regeneration going on in the city centre. And I asked the Chief Exec, I said, this is great, I said, and I was thinking Marmot when I asked him the question. I was thinking, I'll go back up to my Marmot slide. I was thinking, how is this to create fair employment, good work for all in Sunderland? Because they've got £500 million worth of investment. They're building big new buildings and offices. They're building a digital and a film centre, all sorts of stuff. It's fantastic stuff. And I said, out the window, there's some of the poorest parts of Sunderland just out the window from the office. I said, Are they getting a piece of this cake? And he said he got the question. He said absolutely. He said that's a question that worries me more than anything else. He said we really struggle in 2 or 3 parts of the town to engage with the people who live there. Or he said on anything. He said, I want nothing more, Peter, he said, to have those people in these jobs and industries. He said, but getting out to them and reaching to them is really hard. So he got it. He definitely got it. And it's on their agenda. But it is hard. It isn't easy at all. Here's a little example from when I was at Stockton as Director of Public Health. And again, it shows the group most worried about over here. We looked at life expectancy 2011 to 2013. This was stimulated by Stockton having some of I think the widest health inequality as measured by slope index in the country at the time. And there are two things happening here. I live in Stockton. It's my home, not my hometown, I'm from Middlesbrough. I live in Stockton, I've done for 25 years. I'm up here, bluntly. This end is doing fine. And Stockton as a town, if anybody knows it very well, has built some fantastic housing on the outskirts of Stockton. Yarm, Eaglescliffe, Wynyard, where I live. Beautiful housing. Really great developments. Stockton town centre has absolutely stayed fixed there like a hinge. So what's happening is, oh, that's happening. The life expectancy of men in Stockton town centre, because that's really the bottom decile, it says by a decile, but we know where they all live. They all live in the town centre of Stockton. And I know some of Claire's work and some of her PhD students have studied this. Was 68. 68. Well, that's like going back 40, 50 years life expectancy. And so what Marmot says is we need to push, we do need absolutely to improve the mean. That's Rose. And Marmot completely says that. But we've got to do something to help those people up. It's the something which concerns me. It's what is that something we need, because we haven't got it right yet. If we knew, we'd be doing it. I do have a suggestion at the end, but we haven't quite got it right yet. We've really got to find a way of helping those people be more engaged so they actually care about their own health as well as being helped in their circumstances. I want to use this as an example where you have some success. It's not all bad news. So this starts off over here in 1995, and it goes up 2019 is the data. There's something called the National Service Framework for Coronary Heart Disease, was introduced in the year 2000, which was here. But you see, this is mortality from heart attacks. And I use this one quite often when I'm talking to lay audiences, actually, because it's a nice, easy parameter to talk to a group of people who are lay people, talk about heart deaths and heart attacks, is a fairly straightforward concept. And you can see how high mortality, the England average is the dotted line, the northeast of England are the dark lines, how high it was in the mid-1990s. Well, statins became widely available from 1996 to 97 onwards. There was a huge push for statins to go out to the population from the late 1990s. There was a huge push, certainly around 2000, to reduce smoking prevalence. Smoking legislation and smoke-free places came in 2007. So there's a number of things happen. The whole thing has come right down. And, you know, it's great in the North East to narrow the inequality, more or less. I mean, it dots along a little bit now. But, you know, at one point, we actually had lower mortality from heart attacks in men in the North East of England than the national average. Unthinkable when I started in public health, even 10 years before then. The however bit is, the rest of the country is also doing well. So another way of looking at the data, the blue lines are all the mortality rate, directly standardised rates for 1995 for all the regions, and the orange lines are the 2015, this particular data. So there's a little bit here of improving the mean, rows, the whole thing's gone along, but there's something gone on as well where we have helped the bottom end. Now I think that's something, and I've talked to other people around this, is predominantly down to two things. One, we had a massive reduction in smoking prevalence over that time, which proportionally helped the highest smoking populations the most. And secondly, statins and also antihypertensives became massively pushed and very, very hard in the NHS with some big at-scale prevention programmes. And I think that's really Marmot 6, doing more on ill health prevention. There was a lot of that, and we've taken our eye off the ball on that. There's more opportunity for that. And then we're going to talk about this, which is I picked up recently, I think it's quite shocking data. This is data from 2019-20. Sorry, I've lost the data. 2019-20. It's an NHS study looking at children's mortality for the northeast of England. And again, it's by left to right this time, quintiles, least deprived, most deprived. And you can see the gradient across all of them. Sudden infant death syndrome, medical surgical death, congenital abnormalities. The only one where there's no difference, malignancies. And interestingly, Peter picked up that yesterday, where he talked about the genetic things are more or less equally disposed across. So we've got, again, huge inequalities there. That is an inequality we can do something about. We should not accept that. Yes, there's all sorts of structural things going on, but we know where those children are, and we should be doing much better for those children than we are with that. So having the data is a starting point, but there are interventions we should put in place to improve that. I think that's quite shocking, frankly, in this day and age. So just as I wrap up the last few minutes, a few reflections on some of the things in the debates that go on in the public health world and in my world, where we're discussing these things with politicians. And a lot of the emphasis at the moment is around this one I've highlighted, Marmot 6, health prevention. We're talking a lot about secondary prevention, which I'll come on to shortly. A lot about more what can the NHS do about prevention. It's important. By itself, it won't solve it. By the way, just as a guide to anybody, I once made the mistake of asking Michael Marmot in an event like this, in the discussion afterwards. I said to him, so what's the most important thing we should do if we're doing one thing? And like, oh, what a stupid question. He looked at it, it was like, that was a stupid question. He said, all of them. And he got quite frustrated with me. And there's a learning, you never stop learning. So I learned from that. If I'm ever asking him again on a panel, I will ask a far more intelligent question. But what I was trying to get at was, of those 5 things, the things I can control the most in my job as a regional director of the NHS and in the Department of Health is actually that one. That's what I had the most control over. I can do something about that by trying to use the levers I've got for other people in the system to do something around that. It's much harder for me to do some of the other things, although I think the best child in start in life, the previous slide, we're not giving those kids the best start in life. We absolutely could be doing more on that. Current policy approach, well, where we are at the moment now, there's an NHS focus on health inequalities. To some degree, it's a long time since I've known the NHS pays so much interest in health inequalities. So much interest. There is a Core 20+5 programme. There's a Director of Prevention, there's a Director of Health Inequalities. Both are excellent people. They've got good teams, they're doing some really good work. It's quite NHS focused. The NHS is doing this against the challenges which are real. We all see in the front page of the papers. So it's a challenging environment for them to be doing it in, but they're driving it hard. I do think there's a lot more. Again, Marmot 6 we could do on, and Rose actually, on secondary prevention, cardiovascular disease. But we should start by doing the proportionate Marmot bit with the people who need it the most. ICSs have a duty to one of their statutory responsibilities to look at health inequalities. Part of my role, and I know there's at least one non-exec in the room for an ICB, part of my role is actually an assurance of that. So I do have some leverage in my NHS role to ask the ICBs to assure me they are doing work on health inequalities that is targeted in the right way and that they are implementing it. That's a part of the new structure and system that we have. There's a levelling up agenda. We can talk all day about levelling up. However, what's important is government recognises the need to do something. We may all have different views on what that something should be, but there is a recognition there is a need to do something about the current unequal distribution of wealth in the country. Perhaps on a regional level, whatever it is. And there's actually quite a lot of support for devolution in all of its forms. Again, we should go all the way back to McGonagall almost. And then all of these things, we could talk all day about these. Whose fault is it? My fault. Your fault. My neighbour's fault. My parents' fault. Society's fault. How do you make healthy choices easier for people with the McGonagall effect when you've got fixed income? and your rent goes up, or your gas bills go right through the roof, where's your ability to make those healthy choices gone? Choice is great for those with the wherewithal to make choices. Addiction and norms, not just to tobacco, we heard about yesterday, not just to substance misuse or alcohol or gambling, but also to sugary food, fast food. The norm of not being able to prepare healthy food, and not know what to do with a vegetable of any type, which actually a lot of our population have no idea of. And I could talk about all the other bits. And then the bottom one, the economic inequality. If for no other reason, there's an incredibly powerful economic reason to tackle inequalities. And finally, 2 slides. Somebody wrote this around poverty. And I want to focus more than just financial poverty. It is poverty of education, aspiration, role models that really do drive some of these inequalities. Some of these communities, and I've got close to some of these communities in my time, and and I have family members who work in some of these communities. It's really important to understand them, and understand the despair in some of these places. And until you understand them, you can't help them get out of it and find a way of getting them out of it. And then finally, my favourite McGonagall quote: "Poverty, not ignorance, was the cause of morbidity and mortality in the poor. And the poverty is not their fault, but provide them inadequate wages and welfare benefits." McGonagall, mid-1930s. Powerful stuff. So I've just had a bit of a ramble, really. I've taken the privilege of an audience. I've really enjoyed pulling those thoughts together. A bit of a ramble through some of that, some of the way I look at the world, just to really think about some of this stuff. But the key message is, we've really got to find a way of engaging. And financial poverty is massively important, of course it is, but it isn't only financial poverty. It's building hope in our communities. I'll stop there, Ashley, because I know she's got to finish.